Over the last few years, there has been a quiet but very important shift in the way we train neurologists in India. If you look at the National Medical Commission guidelines published in 2022 for DM neurology, it is very clear that neurointervention is embedded within training. Trainees today are expected to understand acute stroke pathways, interpret advanced neuroimaging, and importantly, acquire procedural skills. In fact, the guidelines clearly state that every trainee should independently perform at least 10 cerebral angiograms and assist in mechanical thrombectomy procedures. Training in skill lab also is mandatory. So today's neurologist is not just diagnosing stroke. They are interpreting CT and MRI in real time, identifying large vessel occlusions, making time-critical decisions, performing cerebral angiography independently, and assisting thrombectomy workflows. In most centers, they are already the primary decision makers in stroke care. Now let us pause and reflect. Cerebral angiography is not a minor procedure. It requires vascular access, catheter navigation, real-time anatomical understanding, and complication awareness. If a DM trainee is trained to perform angiography independently, we are already trusting them with the core skills of intervention. So what remains is not a conceptual leap, it is a technical refinement, which means we are not starting from the beginning. So the question today is not, can neurologists do thrombectomy? That question has already been answered by the NMC curriculum itself. The real question is, if a neurologist can perform angiography and assist thrombectomy, how much more training is truly required to make them an independent operator? And the answer is just a focused, structured, interventional stroke fellowship. Now let us bring this to the reality of India. We have 15 lakh strokes every year, thousands of eligible thrombectomy patients, but only a limited number of trained interventionists. This is not a knowledge gap. This is not a technology gap. This is a workforce gap. And right in front of us, we already have a large pool of neurologists trained under the NMC 2022 framework who are already exposed to angiography and thrombectomy. If we already trust our neurologists to diagnose stroke, interpret imaging, and perform angiography, then the only thing standing between them and saving a brain is not capability, but an intense 1-year focused training in stroke interventions. Let us use this vast pool of trained specialists to make mechanical thrombectomy accessible across the country in the next few years. Otherwise, we will still be debating this while patients continue to lose their only chance. The skill is ready, the need is urgent, the time to act is now. But let us be very clear about one thing. This is not about individuals. This is about teams. Stroke care has always been and will always be a multidisciplinary effort. We need interventional neurologists, interventional neuroradiologists, endovascular neurosurgeons, neuroanesthetists, critical care teams, stroke nurses, rehabilitation specialists. The goal is not to replace one specialty with another. The goal is to build integrated stroke teams that can function 24 hours a day, 7 days a week, 365 days a year. Because stroke does not wait, and neither can we. Thank you.